Welcome back to the deep dive. We are really glad you're here with us today.
Absolutely.
We are doing something that I think perfectly captures the spirit of why we do this show. We're going to look at a problem where the map quite literally doesn't match the territory anymore.
Not even close.
We are shrinking down to the size of a microscopic camera and navigating a landscape inside the human body that has been, well, completely radically remodeled.
Yeah.
But to kick things off right away, I want to make sure we credit the architect of today's journey. Today's insights come directly from the incredible video library of Dr. G.S. Raju's YouTube channel.
It is a fantastic resource. If you want to see the real deal, that is the place to go.
Oh, yeah.
Dr. Raju gets into the absolute nitty-gritty of surgical anatomy in a way that is, it's incredibly rare. And honestly, it's exactly the kind of technical depth we need.
Exactly. So before we get into the heavy medical jargon, I want to start with a mental image to ground us. Imagine you live in a city. You know, like the back of your hand. You've lived there for 20 years. You know exactly how to get from your driveway to the grocery store.
Sure. It's muscle memory. You don't even look at the street signs.
Right. But then you leave town for 6 months, and while you're gone, the city planners decide to do some massive permanent construction.
Not just pothole repairs.
No, they physically remove Main Street, they tear up the pavement, they put up a concrete wall, and they build a brand new elevated highway overpass that connects your neighborhood to a totally different district.
That is actually a surprisingly perfect analogy for the medical reality we are discussing today.
Because when you come back to that city, your old mental map is worse than useless. It's actually dangerous.
Right. You'll hit a dead end.
You'll hit a dead end, or worse, drive off an unfinished bridge. Today, we are talking about exactly that scenario, but inside the human digestive system. We are talking about the Billroth II gastrectomy.
It's a procedure that fundamentally alters the surgical anatomy of the patient. It's not just about removing a pathology like an ulcer or a tumor.
Right.
It's about rewiring the flow of traffic in the gut. It changes the physics of digestion.
And the mission for this deep dive is pretty specific. We want to understand the aftermath. Specifically, if that patient needs a procedure down the line years later, how on earth does a doctor find their way around?
It turns a routine diagnostic procedure into a high-stakes navigational challenge. Identifying that altered anatomy is the single most critical step before you even pick up an instrument.
I can imagine.
If you don't realize the roads have moved, or if you don't understand the logic of the new highway system, you're going to get lost. And in the human body, getting lost isn't just an inconvenience.
No, it can have serious consequences. So let's get our bearings. Before the construction crew comes in, before the Billroth II surgery, what does the normal commute look like?
In a standard, unaltered anatomy, the flow is very linear, a straight shot. You swallow, food goes down the esophagus and lands in the stomach.
Okay.
The stomach does its churning, mixing the food with acid, and then the food moves into the antrum, which is the lower muscular part of the stomach. From there, it passes into the duodenum.
The duodenum being the very first section of the small intestine.
Correct. Esophagus, stomach, antrum, duodenum. It's a single continuous tube. If you were driving a camera down there, you just keep driving forward.
You can't really take a wrong turn.
No, because there are no turns to take. It's a one-way tunnel.
Okay, simple enough. But now we have a patient who needs a Billroth II gastrectomy. Maybe they have a severe unmanageable ulcer or more likely these days, gastric cancer.
Right.
Whatever the reason, the surgeons have to go in. What exactly gets removed?
In a Billroth II, the surgeon removes the distal portion of the stomach. That usually includes the antrum, that bottom grinder we talked about, and the pylorus.
So think of it as taking up the bottom third or even half of the stomach.
Exactly.
Okay, so the bottom of the stomach is gone. But that leaves a pretty significant engineering problem, right? The stomach used to connect to the duodenum.
Yeah.
If you cut out the connecting piece, you have a massive gap. What happens to the duodenum?
This is where the remodeling begins and where the dead end analogy comes into play. The surgeon essentially abandons the top of the duodenum. They stitch it shut.
They just close it off.
We call this the duodenal stump.
A stump. So that road Main Street is effectively a cul-de-sac now.
Exactly. It's sealed tight. Nothing can pass from the stomach into the duodenum anymore because they aren't physically connected. That original highway is blocked off permanently.
But the patient still needs to eat. The stomach is basically a pouch at this point. It needs a new exit ramp or the system fails completely.
Right. And this is the genius and the complexity of the Billroth II. Since the duodenum is closed off, the surgeon looks further down the small intestine. They skip past the duodenum entirely and find a section of the jejunum.
Okay.
They take a loop of that jejunum, pull it physically upward toward the stomach, and connect it directly to the remaining gastric patch.
So they are building a bypass, a massive shortcut.
A literal bypass, yes. This new connection is called a gastroduodenostomy.
Gastro for stomach, jejunum for the intestine.
And ostomy, meaning a new opening. So the new route for food is esophagus remnant stomach directly into the jejunum. It completely skips the duodenum.
I'm visualizing this. It's like, since the bridge to the next town is out, they built a tunnel directly to the town after that. But this brings up a physics question for me. You said they pull up a loop of intestine.
Yes.
That implies a change in shape. It's not just a straight tube anymore.
That's the key observation. By pulling that loop of intestine up to the stomach, you've created a tent shape, or more accurately, a fork in the road.
Ah.
Imagine you are standing inside the stomach, shrinking down to our microscopic size. You're looking at this new hole, the gastroduodenostomy. Because it's a loop that was pulled up and cut into, there are now two paths leading away from that connection point.
A fork in the road where there used to be a straight line.
Precisely. One path goes one way along the loop, and the other path goes the opposite way. One path goes upstream relative to the intestine's flow, and one path goes downstream.
Okay, let's unpack this, because looking at the source material, distinguishing these two paths seems to be the absolute crux of the problem. We have two new roads. What are they called?
These are the limbs. We have the afferent limb and the efferent limb. And honestly, confusing these two is the nightmare scenario for an endoscopist.
The spelling here matters, right? They sound almost identical.
They do sound similar, which is why in medical dictation you'll often hear doctors over-enunciate them. The first one is A-F-F-E-R-E-N-T, afferent.
So afferent with an A. Let's define it. What defines the afferent limb?
Think of afferent as arriving. This is the limb that is actually coming from the duodenum and the pancreas. Remember that dead-end duodenal stump we talked about?
Yeah, the road that got blocked off.
Well, the road is blocked to the stomach end, but the biological factories, the liver and the pancreas, are still running. They are still connected to that dead-end duodenum. They are dumping bile and pancreatic enzymes into that stump continuously.
Wait, I want to make sure I get this. The food doesn't go there, but the juices are still being made there.
Exactly. The liver doesn't know you had surgery. It keeps making bile. That bile has to go somewhere.
Okay.
It flows into the duodenal stump, travels down the duodenum, enters the start of the jejunum, and travels up this afferent limb to reach the connection point at the stomach.
Oh, wow. So it flows towards the stomach.
Ideally, it flows past the stomach opening and down the other side, but yes, structurally, it arrives at the junction. The afferent limb drains from the pancreas and bile duct to the stomach area.
And that's why it's so important.
It's the target.
Right.
If you need to access the bile duct, say, to remove a gallstone or take a biopsy, you have to go through the afferent limb.
Okay, so afferent with an A is the target. It's the road back to the pancreas. It's the road back to the old town, so to speak. Then what is the efferent limb? Efferent with an E?
Efferent is the exit. This is the limb going away from the stomach, heading down to the rest of the bowels. This is the path the food takes. Esophagus, stomach, efferent limb, out.
So if you are a doctor doing an endoscopy to check for a blockage in the bile duct and you accidentally drive your camera down the efferent limb.
You are going on a very long, very useless road trip. You're just going to see miles and miles of small intestine. You will never find the bile duct.
You're driving away from your destination at full speed.
Exactly.
That feels like a high-stakes decision. You're sitting in the stomach with a scope. You see two tunnels. One leads to the answer. One leads to nowhere. Is there a signpost?
I wish. In a textbook diagram, it looks obvious. Left is efferent, right is efferent. But inside a living, breathing, wet human body, it can be surprisingly difficult.
The diagnostic challenge.
It's not always immediately obvious which opening is upstream and which is downstream, just by looking at them.
What are the clues? How does a pro tell them apart?
You have to play detective. You look for bile. Since the afferent limb brings bile from the liver, you might see yellow or green fluid coming from that side.
Okay, that makes sense.
You also look for peristalsis, the muscular contractions of the gut. You want to see the wave coming toward you from the afferent limb.
Right.
Whereas in the afferent limb, the wave should be moving away, carrying food downstream.
You're reading the current of the river.
Exactly. But even then, in a patient with a lot of scarring or inflammation, it can be tricky.
So let's escalate the situation. We have our patient with the Billroth II anatomy. They come in with jaundice, maybe some severe abdominal pain, fever.
Classic signs.
The doctors suspect a blockage in the bile duct, maybe a stone, maybe a tumor. They need to perform an ERCP.
Right. Endoscopic retrograde cholangiopancreatography. It's a mouthful, but the concept is simple. Get a camera to the ampulla, the tiny opening where the bile duct enters the intestine, and fix the plumbing.
If this was a normal patient, or even someone with a Billroth I, what would that commute look like?
In a Billroth I, the surgeons reconnect the stomach directly to the duodenum. So the roadmap is mostly preserved. It's the same linear drive. Stomach, duodenum, ampulla. It's a straight shot.
But our patient has the Billroth II. The road is closed.
Correct. So you can't go the normal way. If you try to go from the stomach to the duodenum, you hit that surgical wall of the stump. So you have to perform what I call navigational acrobatics.
Walk us through the route.
You enter the stomach, you find that gastrojejunectomy connection, the fork in the road, and then, this is the critical part, you have to consciously choose to enter the afferent loop.
You have to go upstream.
You have to go upstream against the natural flow to travel back toward that sealed-off duodenal stump. Somewhere along that path, you will find the ampulla of Vater.
That sounds tricky enough, but the material mentioned a specific risk regarding the length of that road. Too long problem.
Yes. This is a fascinating intersection of surgery and physics. When the surgeons create that loop, the efferent limb, they aren't measuring it for the convenience of a future endoscopist.
They're just trying to make it connect.
They are measuring it for surgical tension and blood supply. And sometimes, to make that connection work, that limb has to be quite long.
And scopes aren't infinite.
No, they aren't.
Yeah.
Standard scopes have a working length. If the afferent limb is too long, or if it's very twisty and redundant, a standard endoscope might physically fail to reach the ampulla.
Wait, explain the redundant part. Why does twistiness matter?
Think about pushing a rope. If you push a rope into a loose bag, it just coils up, it loops. The same thing happens with a scope. You might be pushing the handle outside the patient, but the tip isn't advancing, it's just making a bigger loop in the stomach. You lose your voice transmission.
So you could be all the way in scope, fully inserted, and still be inches away from the target because the road is just longer than your cable.
That is incredibly frustrating to imagine. You're on the right road, you've done the hard work, but you run out of cable before you get there.
That leads us to the discussion of tools. Because if you know you're dealing with a Billroth II, you can't just walk in with the standard kit.
Absolutely not. If you look at a standard ERCP tray, the main tool is a side viewing scope, or a duodenoscope.
Why is it side viewing? That seems counterintuitive.
Well, think about the normal anatomy. The duodenum is a narrow tube. The ampulla is on the wall next to you.
I see.
If you had a forward-looking camera, you'd be looking down the tube, not at the wall. A side viewing scope is like driving a car where you have a really high-definition window on the passenger side.
Okay, that makes sense for normal anatomy. You drive alongside the target and look at the window. But for Billroth II, the side viewing scope can be technically challenging.
Technically challenging is polite medical speak for extremely difficult and annoying. Remember, in a Billroth II, you're coming at the ampulla from the opposite direction.
Right, from upstream.
Everything is essentially backwards or upside down compared to the normal approach.
So the passenger window is on the wrong side.
The window's on the wrong side, the steering is backward, and because the scope is designed to look sideways, it is terrible for navigating the twists and turns of that long afferent limb.
You can't see where you're driving.
You're trying to navigate a winding tunnel while looking at the wall. That increases the risk of perforation poking a hole in the intestine, which is a disaster.
So do they switch cars?
They do. The suggestion is that for Billroth II cases, endoscopists often abandon the specialized ERCP scope and switch to a colonoscope or a therapeutic EGD scope.
And these are forward viewing.
Yes. They look straight ahead, like a normal car windshield. This makes it much, much easier to drive through the twists of the afferent limb. You can see the lumen, the center of the tunnel, so you can steer safely.
But wait, I feel like we just traded one problem for another.
How so?
If you use a forward viewing scope, you can drive safely. But once you get there, the ampulla is still flat on the wall. Why don't you just drive right past it?
That is the million-dollar question. You've successfully navigated the treacherous road, but now you have the wrong tool for the actual repair. And this is where the material offers a very specific practical technique.
The roadmap is messy. The target is hidden. How do we fix it?
The fix is to place a cap on the end of the scope.
A cap, like a lens cap.
No, not a cover. It's a clear plastic cylinder, an attachment that extends just a few millimeters beyond the lens. Think of it like putting a clear plastic cup over the end of a flashlight.
Okay, I'm with you. What does a plastic cup achieve?
Two things. First, distance. If you push a camera right up against the tissue, everything goes red. You lose focus. The cap keeps the lens just far enough away to maintain a clear image. But secondly, and more importantly, it acts as a mechanical tool. The technique involves using the cap to press on the folds.
Okay. Because the intestine isn't a smooth pipe, it's wrinkly.
Very wrinkly.
Right.
It has folds called valvulae conniventes. The ampulla loves to hide inside or behind these folds.
Like a coin hidden in a crumpled bedsheet.
That is a perfect analogy. If you just look straight, you see wrinkles. But if you take that plastic cap, press it against the tissue, and gently push, you smooth out the bedsheet. You push the wrinkle aside.
And suddenly, there it is.
The ampulla pops into view. It becomes accessible.
That is so low-tech and yet so brilliant.
It is. And once you can see it and access it, you can perform the cannulation, inserting the wire into the duct, and fix the problem.
Wow.
But you never would have gotten there if you hadn't picked the right scope to drive the road, and you never would have found the door if you hadn't used the cap to clear the view.
It's amazing how much strategy is involved before the doctor even touches the patient. It's not just insert camera, it's what is the history? What is the anatomy? Which tool fits this specific weird roadmap?
Absolutely. And that really brings us back to the core message of the source material. You can be the best technician in the world with your hands, but if you don't have the cognitive map of the afferent versus efferent limb, you will fail.
Let's synthesize this for the listener, because we've covered a lot of biology here. We started with a patient who had a major stomach resection, the Billroth II.
Right. We saw how the surgeons closed off the duodenum, creating that dead end, and spliced the stomach directly into the jejunum to create a bypass.
That created a fork in the road. The efferent limb, which carries food away, and the afferent limb, which brings bile back toward the stomach from the liver.
And we learned the crucial lesson. If you need to fix a bile duct issue, you have to ignore the exit ramp. You have to drive up the entrance ramp, the afferent limb.
We also talked about the gear. Leave the side viewing scope on the shelf because it's dangerous. Grab the forward viewing colonoscope, or EGD, to navigate the long, winding road safely.
And don't forget the cap. Without that clear cap to smooth out the folds, you might be staring right at the ampulla and never see it.
So what's the big takeaway here? If you're a listener, maybe a medical student, maybe a resident, what should stick?
The takeaway is that anatomy isn't static. We tend to think of the human body as having a standard blueprint. The heart is here, the stomach is there, but surgery changes the blueprint.
Right.
The main point we're learning is that knowing the specific type of anastomosis, exactly how those pipes were reconnected, is the single most critical step. You cannot autopilot these procedures.
You have to visualize the remodel.
Yes, the city planning changes before you even start the engine.
It's a great reminder that medicine is as much about navigation and adaptability as it is about biology.
It really is. And knowing that afferent starts with A for arriving might just save you an hour of being lost in the small intestine.
We have covered a lot of ground and a lot of altered anatomy today. I want to remind everyone that all of this detailed information came from Dr. G.S. Raju's YouTube. It's an incredible resource if you want to see the real deal.
Highly recommend it. Seeing the bile flow in real time makes it click in a way audio can't fully capture.
And I'll leave you with this final thought. We talked about how surgeons can completely replumb the digestive system to save a life. But think about the adaptability required by the diagnostic doctors who come after them. They have to invent entirely new ways of moving, switching scopes, inventing little plastic caps, learning to drive backward, just to keep up with the changes the surgeons made. It's an endless game of catch-up.
It's innovation driving innovation. The surgeons change the map, and the endoscopists have to invent a new compass.
Thanks for diving deep with us today into the twisted world of the Billroth II. We'll see you on the next one.
Stay curious.